Debunked, where we bring some pizzazz and personality to the analysis of healthcare news each month. I am Arundhati Parmar, Editor-in-Chief of MedCity News.
And I'm Samir Batra, the Managing Partner for HIP, a venture firm in healthcare.
So, Samir, you and I just got back from Health. I was actually part of the conference. You were hanging around there.
That's right. They didn't get my money.
So why don't we discuss sort of all the news that came out of Health, and I'm guessing you had some similar conversations with folks that you met. So, one of the biggest pieces of news I thought was this announcement from Amazon One Medical, saying that they are partnering with Cleveland Clinic to build these affiliated primary care clinics in Ohio.
Yeah.
So they're starting off in Northeast Ohio with one clinic. They have plans to do more in the future. So the idea is that you'll get in-person primary care appointments there, you'll do labs there, you know, and obviously with Amazon One Medical involved, there's some, you know, all of this is being powered by tech.
Sure.
I actually really like this piece of news because
shocking.
No, it's not. I'm not that cynical. I liked it because to me the model makes sense. So when Walgreens, Walmart, all the CVS Health to a certain extent, they all went out saying that we want to be, you know, the alternative to traditional primary care sites. They poured millions, they bought companies, and then they fell flat on their faces, right?
Yeah.
And so to me, this announcement is like taking into account that, okay, you know, we don't have all the answers. Let's partner with a respected provider in the community and then provide tech-boosted services to a community where the provider is locally based and you know, has relationships with. I think the other retail example of primary care that Walmart and Walgreens and CVS Health wanted to represent was like, we have heft because we are retailers, we're in the community, we'll also provide this level of care. But they X'd out providers that are known and have trusted relationships with the people that come and shop. So I think buying a head of broccoli and buying a bag of chips and picking up your prescription is very different from getting care.
Yeah.
You know, even if it is with a, you know, a clinic in the community that your retailer is sort of sponsoring. What do you think?
Yeah, I mean, I love it. I think it's honestly exactly what we talked about in the previous shows, right? Like when we were talking about all that stuff, I remember both of us were like, why are you not partnering with your provider?
Yes.
So this is an example of stick to what you know.
Yeah.
Right? So you're Amazon, you know consumer, you actually know brick and mortar too because you have Whole Foods.
Right.
So you know how to operate a store. Amazon's acquisition of One Medical gives you that whole concierge model, you know, sort of medicines, or you know how to sort of treat patients or as customers and things like that. And then you have a huge brand like Cleveland Clinic.
Yes.
Let them do the dirty work, meaning the clinical work.
Dirty work.
I mean, you know, clinical can get dirty.
Providers might give a lot of dislike buttons if they had one on this program. But
no, but I mean, you know what I mean? Like, let them do the tough work, let them do the clinical work. And Amazon, maybe this is one of the smartest decisions they've made in healthcare when they've been trying all these different things.
Yeah.
But I think this is a recipe that can be replicated, right? I mean, I think it's, you know, so do you pick the big community provider in your space, the big brand in your space, major retailer, you partner together, you're offering space, you're doing the brick and mortar, you're doing the technology, let the clinical people do what they do best.
Yeah.
So I think it has the most chances of succeeding. And I also like the fact that, like, you know, Cleveland Clinic is big and Amazon's big, and they're going to be like, we're going to go launch like 5 pilot stores. They're starting off with one. Right. You know, so for whatever decision. But I think it's a smart thing. So yeah, let's see, you know, do what you do best.
I completely agree. And I think Amazon has learned from its failures in the past. Like, remember Amazon Cares? They were going to do, you know, primary care for employees. They rolled it out to employers. And again, there was no real uptake, no real partnership with an actually trusted entity, and that thing was shut down.
Sure.
So maybe a model that finally works. We'll see.
We'll see.
Okay, the next piece of news. that I liked. Of course, there's 100 announcements that were coming out at Health. This one that I liked related to GLP-1s and employers. Now, all of you have seen ads on Noom. Ads on TV from Noom Health, they're very good at personalizing programs that help in achieving a healthy weight. So now they've decided they're going to launch 2 programs for employers aimed at GLP-1 medications, rather aimed at people who want access to GLP-1 medications. Very expensive drugs, very effective drugs, although we don't know what the long-term sort of side effects are. They are essentially being hailed as miracle drugs because not only can they help people lose weight, but they have very positive effects on your heart and reduce your risks for heart attacks and things like that. Yeah. So employers are kind of conflicted because they want to offer this as a benefit and yet they don't want it to break the bank. So Noom has figured out 2 programs for employers. One is for employers that absolutely do not want to pay for GLP-1s at all. Right. And in that case, they have said, okay, here's a program, you buy our behavior change program, and then you allow your people to self-pay for GLP-1s. They'll get access to low-cost GLP-1s, some branded, some non-branded, and I think Noom has its own compound pharmacy product. So they get access to all of that, and you, employer, your hands are not tied in terms of GLP-1 coverage. Right. And then the second program that they started, that one actually employers will have to pay a certain amount for that program when it comes to GLP-1 coverage, but they are apparently rewiring the supply chain, cutting out PBMs entirely from the scheme of providing access to this drug. And apparently that's how they can lower the prices. But I thought GLP-1s have become such a major issue. Employers are wrestling with it. Right. This seems to be a reasonable way moving forward. Your take.
Arundhati, did you say cut out the PBMs?
I did.
Oh, yeah.
Oh, God.
Right? Lovely. Right? No, this is smart. I mean, look, first of all, you're cutting out the middleman, right? And you're equipping employers with options, right? Like, it's like, hey, you know what? Here's package 1, here's package 2, you decide what you want to do. And even with the one where they're basically going to cover it, they're creating it like a supplemental benefit. Yes. Right? So it's not a direct benefit. And then what they're actually doing is they're tiering patients based on risk levels. Correct. And then sort of covering based on that. So I think it's smart, right? And I think they can look at their own employee demographic and understand, should we just not cover it all? Should we basically, provide it as a supplemental benefit? Correct. So I think they kind of have a little bit of homework to do in terms of determining the options. The second option, I think that's smart. It's so smart business. Hey, you know what? Buy this program and you get this access for free. Yes. Right? I mean, it's the consumer way. It's the American consumer way. Buy one, get one free, right? So it's kind of like that model. But you're passing on that option to the employee, and then they also hopefully are getting access to multiple non-branded versions, and then you get to make a decision. Now, maybe, hopefully, they're providing some education behind those things. But I think it's awesome. I think, take the burden off, help the employer lessen their burden while still providing the options. And look, over time, if this drug is claiming what it's going to do, you're going to have a lot of knockoffs. You're going to have a lot of non-generics. You know what I mean? Like, you're going to have a lot of options coming out. Generics. Yes. Yeah. You're going to have a lot of generics coming out. And so eventually, hopefully, maybe it will be commoditized. Yes. So till then, you capture the market as much as you can. Yeah. So I love the a la carte menu model. Yeah, and I had a nice interview with the Chief Medical Officer of Personify Health, which works with Omada and Noom and all these people. Yeah. And he basically said that, look, it has become a recruiting and retention strategy. He said that he has encountered situations where an employer has a job offer out, one exact same competing offer, 2 different companies, one offers access to GLP-1s and one doesn't, and people are choosing to use, even if they personally don't use it, they want to probably use it for a family member. So it's become this recruiting tool. Is it coming in your employee offer letter package? Here's a couple of pills.
No. These are injectables mostly.
You know what I mean? Like,
no, I hear you. But the fact that we have, come to this point where a drug is so vital
Right.
to our,
Magic pill.
in a way it is. It's just sad that I wish we wouldn't be in a reactive sort of healthcare system where we also hold like food companies into account. And right now it seems like we'll eat poorly, have terrible outcomes,
Stick
and
myself with a shot.
then get on one of these weight loss drugs like Ozempic or Wegovy or whatever, and then voila, I'm fixed.
Well, I think it doesn't replace. Look, this is good. It should be looked at as a tool, as an aid again,
Yes.
right? Like it can't be a magic pill. I'm just joking about that.
Yeah.
So I think Noom's kind of situated well because they didn't start off like as a GLP-1 pusher, right? They're a pure consumer behavioral lifestyle company,
Right.
and now they're doing this. So I think that's smart. So like your core is still like, look, we're still about behavioral change. Like you still need to make smart decisions.
Right.
This sort of helps you maybe get over the top.
Right.
You know what I mean? Because some people have certain, thresholds that they can't do. So if this drug is sort of helping them get through that last piece of really getting them through, or maybe it's motivating the behavioral change as well, right? It can sort of work both ways. So I think that's smart. I think it's not like a get out of jail free card quickly.
No, I agree with you, but it's just it's the Wild West to a certain extent because from what I understand, a lot of companies are offering these compounded pharmacy versions, and who knows how good these are, and people might be at
digital
risk.
health companies are getting into this.
Yes.
Everything, yeah, for sure.
Okay. And then, of course, we cannot do a wrap-up of health unless we acknowledge the 800-pound gorilla in the room, which is artificial intelligence. I cannot
Where
tell
is it?
you.
Is it here?
I cannot tell you. This is the invisible 800-pound gorilla in the room. Remember, it's artificial intelligence. You can't
It's right
touch
here.
it.
It's sitting right in the middle.
I mean, from a month before health was about to happen, I was getting pitches from public relations companies talking about their clients, and so many, overwhelming majority of pitches I got was to meet an AI company, and I probably met a couple of them. Same thing on the trade show floor. There were zillions of AI firms over there. There was big news coming out of large companies, Microsoft, NVIDIA, Google. They were all there. They were all touting their capabilities. But my reporting so far, in healthcare and MedCity News' reporting is that it's all, when it comes to actual adoption, it's clinical documentation, note taking that has taken off. I don't know what else is being actually adopted. Obviously, radiology is a place where there's big headway. I think there are some studies out there that show that in certain types of indications, AI is better at diagnosing problems and diagnosing disease than an actual human, but we're far from that. We very much have humans in the loop when it comes to AI.
Sure.
And then there was the news that I thought was interesting from GE.
Right.
They actually, and I'm going to look at my handy paper here, they announced that they were launching a new AI platform that harmonizes cancer patients' data and provides clinicians with summaries of their notes and reports. The platform is called Care Intellect for Oncology. It also flags relevant data to help clinicians quickly understand patients' disease progression and identify potential deviations from the care plan. Tampa General Hospital and UT Southwestern Medical Center will be early evaluators of this technology. So I thought that was sort of interesting AI news. Your take on all the AI plethora of information from
AI, always intelligent or always idiotic?
Oh no.
I'm just kidding.
Yeah.
No. AI for all, AI everywhere.
Yes.
It's like God, if you're spiritual.
Yeah.
Right?
Luckily I'm not, but go ahead. Go ahead.
So look, besides the fact that every company in their deck now has AI injected into it or the talk track.
Right.
To be honest, I mean, guys, I don't think AI is a buzzword. It's actually here to stay, right? We may not like it, but we may not like it because it sounds very buzzy.
Yes.
Because everybody's just sort of like injecting it. Regardless of what's happening, it's like, it was like, there's so many of those words over time. Patient engagement, right? Interoperability, remember? Like there's all these sort of themes. Cybersecurity. There's all these sort of themes that come out and then they just sort of evaporate. But look, here's the thing, right? AI is everywhere.
Yes.
Like it's around us. It's around everything we do on our phones, in our cars. I mean, you don't know sometimes there, it's everywhere, right? So I think the biggest thing is that you have to look at AI from a perspective of, is it inward or is it outward? So let me explain what that means.
Yeah.
Right? So first of all, disclaimer, as an investor, I have not invested in an outward facing AI to this date.
What does that mean?
And I'll explain that,
Yeah.
inward and outward. So inward, what that means is, for example, like I've invested in a company that is in this space. You have a medical device that the medical device eventually shows you a reading or shows you some number or some calculation based on where that medical device is being used, right, on a human. So that solution, that product, is actually injecting a lot of data that it's measuring and then is giving you a result, right? So that to me is a safe, effective use of AI. Why? Because that device and all that data that has to be approved by FDA.
Yes.
Right? So they're looking at comparative studies and saying, okay, you're saying you're going to lower, I'm just picking it out of the sky, blood pressure, right?
Okay.
And so they're saying, well, you need to be able to show that your wearable solution, whatever, has the same accuracy as what this, the mom and pop solution of today, which is like, the more manual solution. It's technology, but like you're sort of comparing it to a predicate, let's just say.
Sure.
So that's sort of inward. There's a lot of things that are sort of like, the customer doesn't see or doesn't have to ingest data into, but you're sort of, it's AI, it's almost like, remember we say Intel inside? It's like AI inside, and I don't need to sort of deal with it from the outside perspective, right?
Okay.
So outward would be, yes, exactly what you think, what we're seeing on the data solutions. I have to train my model. I have to inject it tons of data, and then I'm using it to make a decision, right? Or it is summarizing clinical notes for me, or it's summarizing, data for me, or administrative things for me, or whatever it is, or voice dictation, or whatever it is.
Sure.
So that's sort of the comparison, right? And so a lot of us from a outward perspective are a little skeptical, right? Because you've heard this terminology maybe, garbage in, garbage out.
Absolutely.
Right? So you really have to validate the models. And so in healthcare, unfortunately, you can't sit there and just say, oh, well, I've trained my model on all this static data. Healthcare is constantly moving, right? Data is constantly being generated, it's being refreshed. So that's my big question that always becomes, okay, you're training it on like billions or millions of data points. How does that assure the predictiveness of it moving forward? Right. So I think another thing is those AI models have to be constantly training themselves and updating themselves. And I think the other thing is that a lot of people, the comfort level, to your point, from providers or customers and things like that, it's really around non-clinical decision making.
Absolutely.
Right? So it's like you said, it's clinical documentation, it's data. It's basically a tool or a crutch for me to get more efficient, drive down cost, and make better decisions.
It's operational efficiency.
It's operational. It's decision making too, but on non-clinical decisions.
Correct.
Right? So it's like, I think it's there. And so I think the jury is still out. The other thing that I would say that we still need, and I know we don't all love this, but we need some standards.
Yes.
And we need some policing,
Absolutely.
some standards on this stuff, because I think that's one of the reasons why I think you're going to have lots of noise and maybe, I don't think it's going to be few winners. I don't think there'll be many winners, but I think you're going to have, like right now, we're in the noisy period.
Yes.
There's a lot of stuff coming out, right?
Absolutely.
And so I think a lot of that standard stuff is going to really help. The other big factor, and I'll just sort of say it, why have we not seen the breakthrough on the clinical decision stuff? People always say that the initial answer always is, oh my God, you can't take that decision out of the physician's hands. You know what the bigger thing is? It's all about money, baby.
Of course.
Because here's the thing, is Dr. AI going to get covered by United Healthcare and Medicare? It's about malpractice insurance at the end of the day.
True.
The doctor, we are, in this country, in this society, in the world, we provide malpractice insurance to physicians because, hey, you know what? They're human. They might make a mistake. So they need a safeguard, right? Who's gonna provide practice? Who's gonna provide insurance to an AI?
Yeah.
So I'm just saying, I don't know if in mine and your time it'll happen, or our kids' time it'll happen.
Yeah.
Who knows? But I don't see it happening anytime soon. Because there's a lot of work. So I think, because even if government or payers decide to do that, you need a lot of data over a period, long time to sort of see the effectiveness and the safety and efficacy behind the use of AI. To then have monumental changes in pricing and fee for schedule and reimbursement. Till that happens, you're not going to get clinical decision, AI tools where somebody's going to sit there and say, yeah, forget what the human said. I'm going to go with what the doctor said. It'll be on the consumer side. Oh, you can go Dr. Google all you want. But nobody's paying for that coverage.
Sure. So you said a bunch of different things. I think the part about data validation is so true. There was actually the FDA commissioner at Health, and he basically honed in on this issue. That data validation, and no health system is doing it today.
Right.
That part is really vital. The other thing that you said that I thought is interesting is standards. We in healthcare obviously believe that there has to be some standards.
Right.
But I heard a clip of Mark Cuban talking about regulating AI, and he's Mark Cuban, he's a businessman, so obviously he's going to be against. But what he said to me, well, no, he didn't say to me, but what he said and what I saw in the video was basically saying that if we start regulating AI, we will lose the economic race against China, because China is not going to regulate AI, and they're going to win the race. And the next, basically, the interpretation being that the next 20, 50 years of American economic superiority will be harmed if standards are brought in.
I mean, I want to comment on that really quickly. When I mean standards, I mean it for clinical decision making. Okay. Like, Mark, whoever else wants to say that. I'm talking about it from between the options of trusting a human or trusting a machine to make the decision on, like, should I do surgery or should I cut you or not? That is where I'm saying standards. I ain't saying about like cleaning up your administrative workload or whatever. And I'm also not saying that we need standards for AI in like other stuff like consumer, like I'm going to order a Lyft or whatever. Maybe cars, I don't know, like self-driving cars maybe. But my point is, in where safety and efficacy is at a decision making, you got to have standards. If it's not going to put anybody in harm's way, let the wild west run, right? That's my sort of feeling. And then one other thing I was going to say quickly, I have a tip for AI companies that go present to investors, at least to me, because I have a ton of AI companies coming at me. Look, y'all show up, and every single AI company that comes to me, they show me revenue. They're like, oh, and the companies they've started in the last 12 to 18 months.
And they have revenue.
They have revenue.
Wow.
They have revenue in like 3 months. They're like, oh, I started 6 months ago. I have like $200,000 in revenue or $400,000 revenue. And I'm sitting there going,
wow.
Okay, wow, right? The initial thing is, wow, this is the revenue. My God, like so quickly, right? Okay, look, a lot of people are dipping their toes into AI. Practices, providers, whatever, on the safe side, right? Like not on that side, like, clinical documentation. They're doing it. And so, because there's a lot of competition too. So don't get fooled by early revenue, or don't let me get fooled by early revenue, right? Oh, I go sit there, oh my God, great early revenue. What's gonna happen is, if you're getting early revenue, that's awesome. You need to focus on doing some studies, time-saving studies, cost studies, whatever you're saying your metric is that you're impacting. Please, for the love of God, please do some studies, create some data behind it, because there's so much competition. So 2 things will happen. There's so much competition. If you're signing those early customers, somebody else comes out, lowers the price, adds another bell or widget. AI is like SaaS selling, right? It's month to month, it's couple month contracts. So then there you go. So if you're not going back to the core of healthcare, which talks about, I need to make an impact on the metric that I'm telling you I'm going to make an impact on. Then you're gonna die, right? So I think that's really important, because we've seen this story before. Yeah, I'm talking to you, RPM.
Yes.
High engagement,
Yes.
fell off a cliff.
Fell off a cliff.
Right.
Okay.
So that's the thing. That's the danger with AI, with some of these startups that you're seeing that are coming out, raising quick money and getting quick revenue. Where's the sustainability, right?
Yes.
Where are you going to get your first? It's almost like I'm like, look, yeah, all of you are going to come in, you're going to show me 6 months, a year of revenue. Great. All of them going to show that. Actually, if they don't show it, then I'm like, that's a problem. But if you show revenue, that's great. The next step is, what did you measure? What impact did it have? What outcome did it have? And I'm not even saying like a clinical outcome. I'm talking about like, you sat there and said you're going to save, office managers, 60 minutes of administrative work a day. Great. You've had it on for 3 months. Show me the data.
Perfect. Yeah,
Right?
makes sense.
So-
Okay, so we came from a very festive atmosphere in health. I know you were not in the venue, but it was a very festive atmosphere, and we are in Diwali season. So,
Yes, I'm wearing my narrow jacket.
so happy Diwali to everyone. May the light shine on us over a very dark period. And I'm saying this because we're going to publish this video before November 5th, and who the heck knows what's going to happen.
Oh,
on
yeah.
that day.
Oh, yeah,
So,
that thing coming up.
that thing
It's
is
also
coming up.
right before Halloween. Boo.
All right, thank you so much for watching. Again, I'm Arundhati Parmar, Editor-in-Chief of MedCity News.
All right, and I'm Samir. Thanks again, guys.